Hello and thank you for joining in on today's training. Heart and Solutions is a proud provider of CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below to find and take your quiz.
Welcome to another episode of You Need a Training. In today's training, we get to focus on pride in our practice, offering safe spaces and affirming care to LGBTQIA communities. Today's training is presented by Katie Bingner and will focus on the role as mental health providers, our role and ability to be celebrating and affirming our clients' identities year-round. This training will offer the essential building blocks for mindfully connecting with LGBTQIA clients and expanding provider awareness of this community's healthcare needs. Before we begin today's training, I would like to share a little more about our presenter. Katie is a licensed clinical professional counselor and an MD board approved clinical supervisor who works with adults 18 who may be struggling with anxiety, life transitions, relational issues, and unhealed relational trauma. Katie is an integrative trauma therapist, combining action-oriented approaches such as acceptance and commitment therapy with trauma-informed techniques from internal family systems, sensory motor psychotherapy, and accelerated resolution therapy in order to offer a wide range of support to meet clients' current and evolving needs. Katie has worked in many settings, from corrections to private practice, learning valuable lessons throughout her career, primarily that a clinician's skills are only as effective as their presence and attunement. Today, in addition to her counseling work, Katie enjoys offering trainings, communication coaching, and clinical consultation to clinicians seeking support and looking to hone their skills. Katie is a proud member of the LGBTQIA community and is passionate about offering a safe space for any marginalized person in need of affirming care and allyship. So, Katie, we are so grateful to have you present today as we get ready to dive into this training, and are looking forward to being able to leave this training today after debunking some common myths and misconceptions about the LGBTQIA community, and really getting that crash course on affirming and evolving language, exploring the importance and the impacts of holding these intersecting identities, exploring tenets of social justice, as well as helping providers understand how they can improve access to affirming healthcare, and learn more about the straight A's model to strengthen their allyship. So many good things on the agenda today. I am so excited to be here. I am going to let you take it away, Katie.
Thank you, Colleen. I so appreciate that warm welcome. And thank you guys for joining today. I sincerely appreciate you being here so early. I hope you have your beverage area. I do as well. Maybe some snacks, comfortable clothes, hopefully, so that we can kind of glide through this morning training with a little extra comfort, even when we're talking about some of the uncomfortable things that we might wind up getting into today, depending on where your internal kind of status is with working with the LGBTQIA community. So let's jump in to pride in our practice. You did a beautiful job introing me, Colleen. I'm just gonna give a little extra detail about me. That picture there is probably the most important thing you need to know about me, which is that's my sidekick, Chandler. He is right now currently behind me. He takes all sides, but you may or may not get to see or hear him today. I am wielding treats just in case, someone dare walk near or by our house. But if you don't, I promise he is also an ally. And yes, you're very good. He's very affirming and supportive of the queer community. And so he may or may not be making a cameo. I am a cis queer woman. That is how I identify. My pronouns are she, her. I've been practicing since 2015. I consider myself now an integrative trauma-informed therapist because I use a variety of techniques that I've kind of gathered over the last almost decade now to not only offer clients a very present solution-oriented way of navigating their present day struggles, but also trauma-informed methods for navigating the stuff that comes up from the past. As Colleen mentioned, I do offer my private practice services and my communication coaching services. But what you might not know about me is that I was also a licensed massage therapist for 8 years prior to becoming a mental health therapist. So I've also got that kind of holistic, complementary, and alternative medicine side of me that comes in to prioritize a holistic approach to care. You may have guessed, but I am a big animal lover, advocate, rescuer, and I am a proud law enforcement officer partner. And one of the things that I really enjoy doing is being the mental health ambassador for Responders for Pride, which is a national organization that is based here in Maryland. And they provide support and resources and trainings across the country to assist our LGBTQIA plus first responders, but also really just supporting the first responder community in being stronger, more effective allies and helping departments bring on liaisons to help with communication and support. So if you happen to ever work with a first responder who's also a member of the queer community, this is a great resource that you can kind of share with them to help bridge some of the gaps, because I know that the support for our queer first responders varies dramatically, sometimes literally city to city, certainly state to state, and definitely region to region. So that's a little bit more about me. Colleen did a great job kind of flowing through some of our agenda today. So I will just quickly hit on again what we're going to be talking about, starting with debunking some of those common myths and misconceptions of the queer community. We're going to dive into queer vocab because language certainly matters. We're going to gain some understanding about the importance and the impact of holding intersecting identities and how that shows up in our clinical work. We're going to explore the tenets of social justice and how providers can improve access and opportunity to affirming care. And we're going to learn what it really means to be a queer ally and use the straight A's model that I put together in cheeky form to help people really lean into their allyship. So today we are going to kind of start things off with a little kind of exercise. Now, I'm curious, and you can type in the chat, but you can also feel free to just unmute or be unmuted. How many of the abbreviations here can you name?
I could do 5.
Sweet. Look, can you try? Can we hear it?
Yes.
If you're okay.
No.
No worries. If you know, you're like, I'm good with just throwing the number out. That's fine too.
So we have lesbian, gay, bisexual, transgender, queer, and that's all I have, I think.
That's fantastic. That's fantastic.
The last 2.
Yeah.
Is intersex and asexual.
Wonderful. Am I missing any? Are there any missing from this abbreviation that you know of?
Is that why they have the plus, just in case someone else wants to identify as something else?
I love that question. You know what? Yeah.
Mm-hmm.
So you did fantastic, by the way. You nailed it. Together, teamwork. You got them all. I will say that there's a little bit of nuance around the Q. It could be queer or questioning, but and also with the A, it could be asexual, it could be aromantic, it could be agender. But again, these are kind of nuances that you're not expected to memorize. You're not expected to be able to just pull out of your mind all the time. It's just a good idea to kind of once in a while brush up on kind of the abbreviation, because as you know, this is changing all the time, isn't it? This is changing all the time. At one point, it was LGB, then it became LGBT, then it was LGBTQ. And there's always kind of around that time, that's when the plus sign got thrown in there of like, and everybody else, right? And then IA started throwing in. And then also, now if we're going to actually kind of keep rolling with the additions here, we now have LGBTQIA 2S plus, which stands for two-spirited individuals, which we will talk about a little bit later. But yeah, so this plus sign is an interesting representation of kind of everyone else, which has its pros and its cons, right? It's a double-edged sword, because on one side, the intention is to be inclusive and to recognize that there are many, many intersecting and a variety of identities in the queer community. And also, it kind of sucks for people who are deduced to a plus sign. So it's interesting. And again, it's double-edged, but at the end of the day, we're here to just kind of do our best to recognize that there is an incredible variety of individuals and communities and identities that make up the queer community. So we're going to jump in to and you know what? Actually, I want to go back really quickly, because I want to give you a little bit of info, because the flags have also evolved a lot, right? And so this is considered the progressive pride flag. It's the one that I use the most, and it's because it tries to be as inclusive as possible. We've got the kind of classic rainbow representation of LGBT. But we also have the black and brown stripes for people of color. We've got the light blue, pink, and white stripes for the trans community. And we have the yellow flag with the purple circle to represent the intersex community, which I find to be really important to include, because intersex identity happens to be one of the most forgotten or not understood identities in our queer community. So we're going to change that today. We're going to definitely give the intersex community and individuals space here to be seen and heard. So now we'll kind of move into our myths and misconceptions section here. And what I want to kind of lead with is that everything that we talk about today is meant to offer you a safe space as well. And so I'm not here to trick anybody. I'm not here to kind of get you. So I will tell you right now, these are all myths and misconceptions going right into this conversation. But hopefully we can have kind of a deeper conversation around why these myths and misconceptions might continue to be held, and some information that helps to debunk and reframe them. So starting with, it shouldn't matter how someone identifies. We should just treat everyone the same. I would love to hear your thoughts on this particular.
I'm going to just speak up. So I would say that we shouldn't treat everyone the same, because not everyone is the same.
Very good point.
And it feels like erasure, like we're saying like it doesn't matter, like it's a privilege to not have to think about it, you know?
Yeah, you nailed that one right there, both of you. Thank you. Exactly. A person's queer identity absolutely matters, right? In an effort to achieve safety, permanence, and well-being. Now, I do think that this perspective often comes from a well-intended place of wanting to treat all clients with the same level of respect and empathy, and that is important. And also, it's extremely important to acknowledge that not all clients need the same things in order to achieve safety, permanency, and well-being. You know, the queer community faces unique challenges and barriers to care, right? And in order to prevent bias and discrimination, we really do need to be open to recognizing and discussing things like sexual orientation, gender identity, gender expression, et cetera, to do our best in creating that affirming environment, right? We don't want them to feel like hear no, see no, speak no evil when they walk into the room, as they have probably many, many times in their lives, particularly when it comes to the identities that can be hidden, right? The ones that we historically have put in the closet. We want to make sure that our clients can walk into our spaces and feel seen and heard for who they are. So acknowledging the individual experiences of the people that we care for not only truly offers individualized treatment, but it also helps our clients thrive, and it helps us be the most effective providers that we can be. 100%. Number 2, the LGBTQ plus identities are a choice or a lifestyle. That's not true, right? Yeah, right. Like, I'm like, you guys know. I already get the sense that this crowd now kind of knows that that's just simply not true. Science, of course, does support that sexual orientation and gender identity are innate and cannot be chosen, and therefore they are not a lifestyle. However, this can be sometimes surprising, but these particular phrases are still very commonly used in our cultural vernacular to describe or discuss the queer community and queer identity. And I think in my experience, I get the sense that a lot of that can be a lack of familiarity in working with or just knowing someone from the queer community, and maybe this fear of saying the wrong thing. And historically, right, it's been described, these identities have been described as lifestyles. So depending on especially kind of the cultural or perhaps religious background that one comes from, that's going to influence kind of these very nuanced word choices. But we want to be really careful in if we have maybe historically used those terms, we want to be working to kind of shift away from using those, because not only is it not true, but it's extremely invalidating for one's existence. Number 3, LGBTQ plus individuals are promiscuous and they tend to have STIs. Ooh. That's a nasty little one, eh?
It feels like propaganda, like fear tactics.
Yeah, it's a very harmful stereotype, right? That is not supported by the research. In fact, evidence suggests, right, that it's critical for all providers to evaluate multiple factors with an emphasis on individual behavior and predispositions when determining an individual's health risks, right? So in addition to that, bias and negative assumptions about non-monogamous relationship orientations is an ongoing point of discrimination and barrier to effective healthcare. So we're not just talking about the LGBTQ plus identities, but we're also talking about relationship orientations in terms of those who are members of the poly and the kink communities, et cetera. So this kind of falls into that broader spectrum of kind of demonization and dehumanization that is not supported by the research, but also really winds up influencing in a negative way how we literally treat our clients, because it can miss and or stigmatize our clients' health. Number 4, all gay men are effeminate and all lesbians are masculine. No, that's just silly now. Come on, we're beyond that, right? And I think the only thing I want to say about this one is that, in case you didn't know, gender expression and sexual orientation are 2 separate concepts. So the way that we present is different and differs from our sexual orientation. And that can show up in a beautiful variety of ways in, I say the queer community, but I think in general as humans as well, we are quite a spectrum. Number 5, transgender individuals are confused or mentally ill. Yeah, I see head shaking. No, yeah, right. It's not the case. Being transgender is a valid identity. It is now recognized, thankfully, by the medical and mental health communities. But it's important to kind of point out that it's taken a while for us in the medical and mental health field to acknowledge and recognize that trans identity is just another human identity that is not and should not be pathologized. I mean, up until just this most recent DSM, the shifting and the changing around diagnostics and language for the transgender community has been evolving, and so it's still kind of a work in progress, I think, but we're working on it. We're getting there. Number 6, the LGBTQ plus individuals are not fit to be parents. They're dangerous to children, or kids need a mom and a dad. Any thoughts? Have you come across ever in your work these myths, misconceptions, ideas?
I think luckily for many of us, hopefully not so much at work, but definitely in the community, right? And out and about kind of in that real world space and overhearing things, or even in in media and mainstream media, and how some communities are portrayed in various situations. So
yeah. Again, going back to the shifts from city to city, right? State to state, region to region, it can really vary in terms of how much these particular ideas, misconceptions are held. But at the same time, more than 3 decades of research shows equally good outcomes for children of LGBTQ plus parents as those with cis hetero parents. Studies also show that queer people's relationships are no different in quality, shock, than those of heteronormative couples. There are studies that speak to the benefits of a 2-parent household, but they say nothing about the gender of the absent parent being the cause of the unfavorable outcomes. And then finally, this last one, which I find to be one of the more provocative ones, and still oftentimes when I do this training, I have very honest people that I appreciate kind of speaking in terms of like recognizing that they're like, yeah, I still kind of struggle with this one. And it's that kids and teens are just too young to know that they're queer.
I think that makes them feel really unsafe when you feel like, I know this about myself and people are questioning you. It starts making you question yourself.
Absolutely. So it's a really difficult thing, I think, to navigate for providers who work with kids and young teens, because you're also working with family, right? You're typically working with parents, and a lot of times this is where that struggle can arise. And then when we try to put the therapeutic lens on trying to find understanding education and effective communication around these difficulties, that's where it can get really complex. On its face, we can kind of sit here today and say, like, no, right? Like that, come on. But some information that might be helpful to have in your back pocket around this, especially if you are having these more difficult conversations with parents and their teens, is that there has been some research done around this particular topic. One study of queer youth found that 75% recalled feeling different in childhood, and that awareness usually came between the ages of 4 and 12, but as early in this study as 3 years old. Most participants in this study first openly identified as queer in the adolescent phase of life, 12 to 16 years, which is right on course with all of us in terms of our identity, and particularly our sexual identity and gender identity starting to develop. Another study of transgender youth found that the average age of talking about feeling or their gender being different was 5 for trans girls and 8 for trans boys. And it was not uncommon in this study for participants to recognize that their trans identity as early as 2 years old, which I think is pretty incredible. The reality of the work that we do, especially with teens and young kids, is that people are coming out at younger ages than ever before, right? Adolescence, of course, involves exploring and coming to an understanding about your gender identity, your expression of gender, and your sexuality. And so young people often demonstrate an evolving understanding of those aspects of themselves, but this exploration and evolution, it doesn't mean that it's impossible for a young person to have insight and understanding about who they are. And oftentimes, as adults, maybe the adults that are struggling with accepting this can relate to that understanding that there was an evolutionary process to developing who they were and those nuances of their identity in adolescence. Now, some young people who are questioning their sexual orientation, gender identity, and expression may feel pressure, right, from within themselves, from their peers, from their families, to choose a label or to figure out, right, kind of like how they identify. And they might feel frustration from people if their identity seems to be shifting or evolving as they figure things out. But questioning youth should be supported, nurtured, and assured, right, that it's absolutely normal. This is a normal process of being human and growing up and figuring ourselves out. And it is okay to explore this. It is okay not to know. It is okay to not have a clear concept of self quite yet. But it is interesting because the amount of pressure that's put on queer youth far outweighs that of cis hetero youth. So that speaks volumes.
And Katie, I don't know if you're aware, but state specific, right? So that our Iowa providers, if they're not aware, Iowa is currently has legislation on the table looking to essentially join some other states in what's been known as the Don't Say Gay legislation. And so what they are proposing is that kindergarten through 6th grade elementary teachers will not be allowed to use any sort of language that is inclusive of LGBTQIA plus communities, including any materials in books. It prohibits a lot of health education. It prohibits a lot of things. And so thinking about, challenging that myth of young children and the uphill battle that we continue to fight to even be able to open those conversations for kids who may not be getting them elsewhere.
Yeah, absolutely. Thank you for bringing that up. And we are going to talk even more about those pieces in a little bit, but it is incredibly important, like I was mentioning earlier, depending on where you are practicing, you are going to be experiencing different levels of challenges around having conversations and providing affirming care, especially to youth. And so, so that's such an important thing to bring up, especially for viewers who I know are going to be primarily from that area, and being aware of the local state legislation that's going through, because we are experiencing a immense wave of anti-LGBTQ plus, particularly anti-trans legislation coming in. So yeah, like I said, we're going to talk a little bit more about that in a bit, but it's incredibly important to know, if we're going to be providing affirming care, what's going on in our neighborhoods, our backyards, etc. All right, let's talk about terms, shall we? Because language is incredibly important. And so when we talk about why language is so important, I think that the basics here is that using respectful language is really crucial for treating all our clients. And when we speak about the LGBTQ community, we want to remember that this community has been long forced to hide in the shadows, right? Kind of like we were talking about earlier, this concept of erasure and being hidden. They've also been marginalized and discriminated against at every turn. And so using language that's insensitive or derogatory can further perpetuate these harms and traumas. Using respectful language shows that you value and acknowledge the dignity of every single individual that you treat, and it is very much foundational for providing affirming care. It's important to use language that reflects an understanding of the evolving diversity within the queer community. So for example, using the correct pronouns and identified names of your clients is really essential, right? For that base level of respect, to build rapport, and offering a more warm, welcoming, supportive environment overall. So I have created a cheat sheet for you. You don't need to write all these down, and you certainly don't need to memorize them, but they're incredibly helpful to have nearby. Doing this training is kind of a part of my practice, because whether you're a member of the queer community or not, you're not an expert in every identity. So it's important to have this information kind of nearby. Sometimes offices that I work with will print them out and kind of put them on like a bulletin board nearby, a community area where it's just always in your purview. Some providers will put them on their own kind of bulletin boards or desks, just to have it there in your present awareness all the time and be able to update it as needed. So we're going to start with kind of the vocab 101, right? So these are the terms that are going to be important to have an awareness of, an understanding of when providing inclusive care. Let's start with gender identity. That's a person's internal sense of themselves as male, female, both, neither, or another gender. Now, I know that as I went on with that list, it got more challenging for some. And that's okay, because we're familiar with the binary of male and female, and we're less familiar with the concepts around gender being neither or another gender, but we will get into that more, so don't worry. Sexual orientation. This is a person's emotional, romantic, and/or sexual attraction to others. Pronouns are the words used to refer to someone's gender. For example, he, him, she, her, they, them. Transgender is a person whose gender identity differs from the sex they were assigned at birth. One really important note that I like to make here is that a common slip of the tongue is to say transgendered, and that is not what we want to be using in terms of this term. The way that I help people remember that, the way I remember that for myself, is that you wouldn't say someone is gayed or lesbianed or queered. And so that's like a nice little reminder in our minds, because for whatever reason, I think sometimes it really is just a slip of the tongue, and our brain kind of can get glitchy around like, oh, wait, which is it? And then we can have a tendency to use the incorrect one. And so it's transgender, not transgendered. Cisgender, which is a person whose gender identity aligns with the sex they were assigned at birth. Non-binary is a gender identity that does not fit within the traditional binary of male and female. This can be a wide net, and it can also be referred to as gender fluid, gender queer, and others. But those are the ones that pop right out of my head right now. Queer is an umbrella term used to describe individuals who identify as non-hetero and non-cisgender. In terms of, queer, that term, I'm aware for older generations is really associated with bigotry and is a derogatory term. And that is true for that part of our history. It was used as a derogatory term. However, like a lot of terms in different marginalized communities, we have reappropriated it into a positive identifier. And so particularly for younger generations, those of us who, I can speak for myself, who did not have that experience associating the term queer with negative association or any form of kind of like discrimination or attack toward myself, I find that to be a more appropriate identifier for myself. Again, it's an umbrella term, so it really allows for more fluidity in identity and less rigidity around labeling ourselves as this exact thing or that exact thing. And then intersex, which I promised we would talk about a little bit more. Intersex is also an umbrella term that describes bodies that fall outside of the strict male-female binary. There are many ways that someone can be intersex. And so we're talking about anatomy here. But we're also talking about how anatomy then can influence gender expression and gender identity and sexual orientation. But in terms of different types of intersex identity, I'm just going to kind of name a few for you, just to give you an idea that there is a very rich variety of identity in the intersex community. So there is true gonadal intersex. Those are individuals who have one testicle and one ovary, which is rare. It is more common for people to have gonads that contain both testicular and ovarian tissue. So as you can imagine, that affects an individual's hormones and endocrine system functioning. We've got also androgen insensitivity syndrome, which is a genetically male person who is resistant to male hormones, resulting in some or all female physical traits. And then we have congenital adrenal hyperplasia, or CAH. And that's the most common iteration of intersex identity. This is individuals with 2 X chromosomes, and it affects about 1 in 10,000 to 18,000 children. Any questions so far? Okay, we'll keep it moving then. So I'm really confident that we are ready to move beyond the basics. I know that this crowd particularly today is probably feeling pretty confident in their communication based on our conversation so far today, but let's build even more confidence around the language that we can use and that we have available to us when we're working with, not just working with the queer community, but when we're referencing and educating maybe our colleagues about the queer community. These are some terms that help to boost our confidence in being able to communicate about this. So before we jump in, as you see, a lot of these terms have GE next to them. And so we're going to talk a little bit about gender expression here. Gender expression is how a person publicly presents their gender through their behavior, their appearance, and their mannerisms. Starting with androgynous or STEM, this describes someone who presents as neither male or female in terms of androgyny. STEM or STEM, which you can see is differently, two different ways to write that, is primarily used within the Black and Latin lesbian community to describe someone whose gender expression is both masculine and feminine. And so there's a little bit of nuance there to be aware of. Butch or masc describes someone who presents as masculine. Now, as just with queer, butch has and continues to sometimes be used as a derogatory term for masc lesbians, but it can also be claimed as, again, an affirming identity label in that community. Femme describes someone who presents as feminine. Now, chosen family is a really, really important term that I want all providers to be aware of, but I have found in doing this training that it is actually one of the lesser known phrases. Just show of hands, has anybody heard of the term phrase chosen family? Fantastic. Love it. I knew it. You guys are awesome. But so chosen family is incredibly important when providing any kind of care because, as you know, we spend a lot of time gathering data and information about a client or a patient's family of origin. And what we want to be able to do is inclusively ask about an individual's entire support system. And that would include their chosen family, particularly for those in the queer community who have been estranged from their family. And that is commonly because of their queer identity. And so it all links up, and it's very important because this might be the only real family connection that some of your clients or patients might have. But in terms of what a chosen family is, it's a group of people who are not necessarily biologically or even legally related, but they play a significant role in each other's lives. They provide that unconditional and mutual love and support, and it can go really in depth in terms of even helping people who are unhoused be housed, helping people through their family of origin trauma. It can be a really important key piece of someone's lived experience. So we want to be asking about their chosen families. Drag is the act of performing a gender or presenting as a different gender, usually for the purposes of entertainment. And so you've probably heard of drag kings and drag queens. In particular, when we talk about drag, which is another existence and identity that's been really brutally attacked legislatively and culturally recently here. But when we understand the drag community a little bit more, we want to understand that in some instances, those who perform drag also identify as trans. And so individuals might even start out performing drag as a part of their journey toward discovering their authentic gender identity. So we don't want to just assume when we hear, oh, well, I'm a drag king, I'm a drag queen, I perform drag, I spend my weekends doing drag. We want to be curious about how that interplays with someone's identity in a deeper way, because that's going to give you so much more information than just kind of what seems like maybe a job to some. Now, gender dysphoria and gender euphoria, these are really also important clinical understandings to have. Gender dysphoria is the feeling of significant discomfort or distress related to one's biological sex, gender identity, or expression. Whereas gender euphoria is the feeling of significant rightness or comfort with one's sex, gender identity, or expression. And it does say biological there. And so it's this idea that we can experience gender euphoria in a number of different ways. And typically that has to do with someone feeling aligned with, right? Discovering the aligned feeling of how they identify and then their biological experience of their body. So as I was mentioning earlier, it's been a slog getting our medical and mental health communities to kind of understand and get on board with these concepts around gender and gender identity. And so gender dysphoria is the most recent iteration of diagnostic language for those who might be experiencing that struggle if they are trans or non-binary. And that replaced the previous diagnosis of gender identity disorder, right? And so the idea here is to focus on the clinically significant dysphoria around that experience and not on the identity itself. So we're getting there. We're trying. This last bit of vocab we're going to go over covers a bunch of different things, starting with misgendering and dead naming. These are two, again, really important terms that we want to be aware of, especially in the clinical world. And so to misgender or dead name someone is to refer to someone using a word, pronoun, or name that does not correctly reflect the person's gender identity or chosen name. So you probably know that this can be offensive and quite harmful, particularly if you're doing this purposefully, right? I think that's kind of common sense there. But one thing I really want to speak to is that accidentally misgendering and dead naming someone is also really understandable. This happens all the time. It happens all the time. It happens within the community. And so what we want to be focusing on in terms of how to remedy that, how to address that. Well, let me ask you guys actually really quickly. How do you think, if you want to chime in, if not, that's okay. But how would you want to go about addressing or remedying a moment of misgendering or dead naming someone?
You just correct and move on.
Nailed it, Susan. Absolutely. Do not over apologize is kind of the key piece, right? Address it, move on. If an apology is necessary, make it quick, make it efficient, move it on. We don't want to turn this mistake into then this situation where the person who has had to deal with this time and time again now has to take care of you and the embarrassment or the guilt that you feel. We don't want to burden the individual with having to kind of tell you it's okay, it's all right, it's okay. Nope. We just address it, we change it, we apologize if needed be, and we move it forward. Next, we're going to talk a little bit more about pronouns and neopronouns. Again, pronouns are, I think, now more commonly heard, understood. It's more in the kind of the common vernacular: he, him, she, her, they, them, right? They, them, theirs, used in the singular, of course. The neopronouns are a little bit less understood, or people are less familiar with them. And so sie, their, theirs, I am, heirs, and others that are evolving. We might be running into this, particularly if we're working with, again, youth. And so we want to, again, just be very open and willing to making a note, giving ourselves tools to remember how to properly identify and acknowledge and communicate with this particular client, like we would any client, right? I kind of try to simplify it in the sense of, we've got at the top of every chart, we've got the client's name. And we don't just intermingle names, right, with different people. And so it really can be as simple as recognizing that if we can put that note of the proper pronoun or proper neopronoun in front of their chart or somewhere where you're going to remember it, it's going to be more likely to use the proper pronouns or neopronouns for somebody and their proper name. And at the end of the day, I think one of the biggest struggles can be someone, and perhaps maybe the implicit bias of it all kind of holds them back and saying, I don't understand, I don't get this, like, what's the point of this, etc. You don't need to. Remember, you don't need to fully understand who and why someone is. The idea is that we are care providers. We are here to work for and treat every single person that walks through our door with respect, dignity, and afford them that safety that they deserve in these very vulnerable clinical relationships. So help yourself remember, and probably do some of your own work, as we'll talk about a little bit later, if you want to better understand the communities that you're working with. We talked about transition. That's a term that you may or may not wind up using throughout your care, but it is the process through which some transgender people change their gender expression to more closely resemble their gender identity. Do not assume that all transgender people will be transitioning in each and every way that they can. So we want to be curious. We want to inquire if it is relevant to care about how an individual aligns with themselves, their identity, and if that incorporates, changes to certain elements of their biological body or of their expression, and provide them that safe space to talk about that, consider those options, and explore that. And then we've got Two-Spirit, which I mentioned earlier. Two-Spirit represents a variety of different types of identities. It can span across gender expression, gender identity, and sexual orientation. It is another umbrella term used within some Indigenous communities of North America. And the idea is essentially it kind of bridges these understandings of gender and sexual identity between Indigenous and Western worlds. Now, the term is used by some Indigenous and First Nations people to describe folks who are not straight and or cisgender. So it's somewhat similar to the term queer. Two-spirit identity can be used to describe, again, sexual orientation, gender identity, and also spiritual identity. And it may encompass same-sex attraction and a wide variety of gender variances. It can also include relationship structures such as polyamory, a non-monogamous or ethical non-monogamy, etc. Now, we're going to shift gears a little bit, and we're going to keep it moving to explore these intersecting identities and how that impacts not only how we offer care, but how care is received. Intersectionality, if you're not sure, is a concept that recognizes that people can experience multiple forms of oppression and discrimination at the same time due to their identities and or characteristics. Intersectionality was first coined by Kimberly Crenshaw, a civil rights activist and legal scholar, to describe the unique experiences of Black women who faced both racism and sexism. When it comes to the LGBTQ+ community, intersectionality acknowledges that individuals can be discriminated against and marginalized not only because of their sexual orientation or gender identity, but also due to their race, ethnicity, disability status, age, socioeconomic background, body size, etc. So we're going to just talk a little bit, because this is a vast topic for a short training. So we're going to touch on a couple of different key points here around intersectionality and different communities that experience it. Starting with the Black queer intersectionality, which is really vital to consider when offering affirming care. Separately, you probably know that these two communities have faced a majority of historical persecution, oppression, and discrimination. That continues today with sweeping legislation against queer people of color across the country and also the world. When you hold both of those identities, the mental, emotional, and physical toll is then significantly compounded. This is evidenced by elevated rates of suicidality, depression, and anxiety among Black queer youth who are more likely to experience discrimination and harassment because of their identities when compared to their white peers. Now, a really important note that I want to make here is that the Black queer young identity is not inherently prone to suicide risk because of their race, sexual orientation, or gender identity. It is the experienced higher risk because of the mistreatment and the stigmatization by society. And so it's how one is treated. It is the barriers to care. It is the violence and discrimination that they are exposed to versus their actual identity. That is the problem. Another intersectionality that I think is really important to highlight is body size, which can result in discrimination and oppression, particularly in the healthcare industry, but also in employment, media representation, as well as just stigma and bias from others in the community. People who are considered fat or overweight often face harsh criticism and shaming from their healthcare providers, much of which is based on narratives that are historically racist and inaccurate. So in fact, sociologists now point out how changing cultural attitudes about weight between the 16th and 19th centuries, overlapping with the transcontinental slave trade, were directly correlated with beliefs around racial superiority and inferiority. So body size was just another tool used to differentiate between those who were going to be afforded power in society and who wouldn't. And those beliefs stuck, right? Over time, they made their way into modern medicine. And one major example is BMI, body mass index. BMI is a measure of the ratio of a person's weight to their height. And it was never intended to be used to measure individual body fat. If you ask me, BMI is a BS health measure. It does not account for bone density, muscularity, and any other type of genetic influences on body size or shape. So what winds up happening is that you might have two people with the same BMI, right? But vastly different life experiences and body compositions outside of the simple reality of their height to weight ratio. Now, this creates a very serious problem when then using it to measure an individual's health. For example, based on decades-long research, at least since the 80s, African American populations tend to be healthier at heavier weights compared to white populations. So BMI-driven healthcare particularly causes harm to Black women because the message being sent primarily to them by their medical providers and other types of providers is basically that your bodies are inherently unhealthy, right? And this type of fat stigma leads to worsening health outcomes. So it's really, really important as providers, especially as mental health providers who are going to be with our clients, climbing that uphill battle, facing medical providers who are holding these unfortunately inaccurate and very harmful beliefs as fact and medical, as medical fact. It's incredibly important that we then familiarize ourselves with models and approaches that are actually health-driven and more socially just. And so I've got a couple here listed that I use. One is the Hayes model or movement, which is health at every size, and the other is intuitive eating. Just curious, has anyone heard of either of those? Yeah, shaking. Yeah. Nodding heads. Great. And so in that case, I'm not going to dive any deeper, but I do encourage, if you have not heard of those, do a little bit of your own research, explore them a little bit more. I do think that it is an incredibly important approach to have when you're working with anybody, because I have found that, again, body image issues, right? Body dysmorphia, these types of struggles show up, whether someone comes in with that struggle to address or not. And so it's really, really important that we have at least a base understanding of how to help our clients when they are experiencing this particular intersectionality. Another hugely overlooked intersectionality is between the queer and disability communities. So LGBTQ plus people are more likely to be disabled than non-LGBTQ plus people. That increases the amount of discrimination and bias that they face in their daily lives, at school, and in healthcare settings or at work. The barriers that disabled queer people face often start early in life. For example, disabled LGBTQ plus youth experience elevated rates of bullying, and that can often lead to elevated dropout rates. In fact, this astonished me, and I had to share it when I was doing my research and putting this together. The truth is that disabled queer people face higher risk of discrimination than both their cis hetero peers with disabilities and their queer peers without disabilities, which of course causes additional harm, right? It causes them to avoid care and then have to deal with unmet health needs and greater health risks. There's also a number of systemic barriers like trouble accessing proper transportation, inadequate healthcare coverage, just not even being able to find adequate mental health care or medical care. These are very, very real realities for the disabled community. And one thing that really, I think, drives the point home here, which blew my mind, which I think highlights my naivete and my privilege, is that last year, in late September, is when the NIH finally designated people with disabilities as a population with health disparities. And if you're wondering why that's important, among other things, it's this designation that allows the NIH to put more money into researching, right? They have to conduct research into this community's needs and experiences so that it can be better served. And it took until last year to make that designation. So these things are not as well addressed as I think many of us assume that they are. So I obviously cannot cover all intersectionalities of identity today, not just because of time, but because I'm not qualified to be honest. But what I do hope that you're able to take away is that with each intersectional identity, an individual may face additional obstacles, discrimination, and oppression, both individually and systemically. And so we want to really gear our clinical curiosity toward an individual's intersectional identities and make space for that to be explored and for a collaborative approach to helping provide effective care. Now we're going to talk a little bit about social justice. So the National Association of Social Workers defines social justice as the view that everyone deserves equal economic, political, and social rights and opportunities. But as we know, and as we mentioned earlier a little bit, the unfortunate truth, of course, is that we are far from realizing this as a reality for countless people, not just in our country, but around the world. Today, we are going to narrow our lens to focus on the social injustices faced by the LGBTQIA2S+ community here in the US. So what you've learned so far undoubtedly highlights the elevated rates of trauma experienced by members of the LGBTQIA2S+ communities. And who do these folks go to for help? Us, right? Sadly, healthcare professionals are not always allies, and they often receive very little LGBTQIA+ competency training, specifically in the medical field. And while blatant discrimination may be illegal, the healthcare industry is still very much affected by societal queer phobia that negatively impacts the quality of healthcare that queer people receive. In fact, according to a December 2021 statement from GLMA, which is the oldest and largest association of LGBTQ plus and allied health professionals, more than half of all medical schools lack any queer-focused health training beyond treating AIDS. And a 2018 report from the Kaiser Family Foundation noted that more than half of LGBT people reported that they have faced cases of providers denying them care, using harsh language with them, or even blaming them and their sexual orientation or their gender identity as the cause of their illness or issue. There are currently just over 200 LGBTQ specific healthcare centers in the entire United States, and not all of them provide services like mental health care or pharmacies. 13 states have no LGBTQ specific healthcare centers at all. And the suicide risk in the queer community is thought to be highest during the teen and early 20s years. Research has found multiple factors associated with suicidal behavior among queer people, including isolation from peers and family, a history of mental health issues like depression and anxiety, substance use disorders, and ongoing chronic victimization, whether it be the target of bullying or other forms of abuse. Conversion therapy. Who here has heard of conversion therapy?
Unfortunately.
Right? Exactly. Unfortunately is what I was thinking too. So yes, conversion therapy refers to a range of dangerous and discredited practices aimed at changing or curing one's sexual orientation or gender identity. Its origins date back to the turn of the 20th century, and it continues to incur great cost to the queer community and society as a whole today. In fact, a recent study conducted by the Trevor Project estimates that conversion therapy continues to bring in $650 million annually. That study also found additional costs associated with the harms of this practice, such as substance abuse, depression, anxiety, suicide attempts, all significantly higher. And so an estimated $8.58 billion annually is used to treat the effects of this type of practice, bringing the total cost of conversion therapy to $9.23 billion annually. So it is significantly affecting our culture, our society, not just within the queer community, but as a whole. And as mental health providers, we can play a really pivotal role in expanding access to the queer affirming therapy that all individuals need, but particularly those who have been traumatized and are healing from the experience of conversion therapy. We have the opportunity to empower young people and anybody who's experienced this to help them accept themselves for who they are and promote positive health outcomes and recovery. And then another note that I want to make here is the awareness that there is struggles within the community as well. I think that sometimes many assume that there's kind of an inclusive safe haven that's provided to all members of the queer community by default. And that's just sadly not the case. Some examples include those who are aces or asexual. Their identity is often just flat out criticized or invalidated. There are trans exclusionary feminists who deny transgender women the right to identify themselves as women and believe that they should not be allowed to access women's restrooms or participate in sports. bisexuals are historically labeled as not queer enough, are thought to be confused and not truly a member of the community. And of course, there's this idea that we talked about earlier, which is the plus sign, right? This kind of natural deducing of an identity to a symbol like a plus sign. And those who are members of the plus, right, often experience these types of mocking and exclusionary behaviors and treatment. So it can be a real struggle for those in and outside of the community. So we cannot talk about social justice without talking about voting, because voting really matters. Maybe now more than ever before, but certainly just as much as ever before. As of June 28th, according to the ACLU, 527 anti-LGBTQ+ bills have been introduced in state legislatures across the United States this year, as we were kind of mentioning before in our conversation. Here are just a few of the highlights. 16 of those bills have been designed to limit the ability to update one's gender information on IDs and other important records. This is an incredibly impactful set of legislation, because we all need accurate IDs, don't we? We need IDs for employment, travel, legal interactions and proceedings, and to enter public establishments without risk of discrimination or violence. So if passed, these bills would put trans, intersex, and non-binary people at greater risk for not only violence and discrimination, but thanks to an increase in discriminatory voting legislation, it can also obstruct one's right to vote. So just some examples here. Last year alone, North Carolina, North Dakota, Utah passed this type of legislation. This year, West Virginia passed this type of legislation. Additionally, 206 of these bills are school related. So they are pertaining to facility bans, bathroom bans, curriculum censorship, etc. And 59 of those 206 are related to forced outings by teachers and staff. So this particularly targets trans youth. It aims to reveal private information about trans students, regardless of whether the student consents or whether they might suffer negative or harmful consequences at school or at home for the disclosures. These are really, really harmful bills that are being presented here. 90% of queer Southerners live without any non-discrimination laws. And in North Carolina alone, 6 bills have been filed. More than that, I'm sure, at this point now, ranging from healthcare restrictions to sports restrictions and forced outings in schools. This directly impacts, like we were talking about earlier, when your state is introducing a number of anti-queer bills, you are going to feel the quick trickle down effects of that in your clients, because they're going to be coming to you for help to process, to cope with, and to navigate these discriminatory bills. And so we want to be keeping abreast of that situation. Just so you know, the ACLU here, the ACLU mapping attacks, having that, checking in on that, it's a very user-friendly site that gives you up-to-date information about the bills, about the issues, about what's been introduced, what's been stalled, what's been passed, what's been not passed, or I can't remember the other word that they used, but that failed, essentially. It's a very useful tool in keeping up, particularly with your state's legislation movement. And I'm not going to go through this in detail, but I just wanted to show you visually, for example, the obstacles that one faces if they simply want to change their identification These are the steps that one would have to take in North Carolina to update their important documents to reflect their accurate identity. So they would have to obtain 2 sets of fingerprint cards from the sheriff's office. They would have to complete the FBI and SBI investigation criminal background check. They would have to file a notice of intent to change with the civil clerk. They have 10 days after filing to notice, any of these potential things. And then after filling out the documents, they would have to move through the final approval process. And then, of course, update their voter registration. And all of this comes with financial burden, time burden. And it's not to say that we don't want effective steps to make sure that we are able to obtain accurate identification. But this is to say that queer individuals face numerous hurdles in addition to these types of things. And that is why a pretty high percentage, around 21% of the queer community, don't have accurate identification that reflects their gender identity and name. So social justice is really about helping to lift some of the burdens that marginalized communities carry and to do our part to increase access and opportunity to equal rights and quality care. So this last phase of our conversation today is going to be about allyship and how to really lean into being an affirming and inclusive provider. And in case you didn't know, this is the ally flag. So what is gender affirming care? Gender affirming care is different types of treatment interventions that fall along a continuum. Transition care and support might start with cosmetic changes, and it might move toward more intensive interventions, ideally drawing from a team of physicians, mental health counselors, and non-medical caregivers. So I'm curious, what are your guys' thoughts around gender affirming care? Like, what do you guys think about when you think about, okay, what are the different types of gender affirming care? What comes to your mind?
Katie, I was rereading your slide because I think it's one of those things, especially as professionals who kind of promote inclusive care and gender affirming, right, to kind of go, oh wait, right, like, am I doing this correctly? And so for me, I mean, I think keeping in mind, like your slide talks about, right, but a range of care. And so at that very, very, very direct level, working with individuals, who are seeking that medical support to affirm their gender identity, right? But I think on that larger scale picture too of, okay, what is our entire agency or office or, kind of piece doing to make sure that we're gender affirming throughout, and not just when a client is specifically identifying that they, are seeking care for reasons related to gender identity or anything like that.
It certainly starts right with the environment and kind of sitting with the person who's in front of you and asking, those curious questions around how can this treatment, this care, this support affirm your identity, right? And okay, here we go. We've got another message in the chat here. Gender affirming surgeries and assessments. Yep. Utilizing pronouns properly, being open and accepting, unconditional positive regard, much more. Absolutely. Those are everything that you guys have listed are like kind of those common things that we think about when we think about what does gender affirming care look like? And of course, we're looking at it from the lens of the counseling perspective. So I've got this list of really, some of them really kind of like, oh, right, of course, ways that someone can receive care. We're kind of broadening our lens here of care in the terms of even outside of our offices, even outside of our sessions, what are some of the avenues of care that someone can engage with to affirm their identity? And so, yes, starting with counseling, mental health, receiving support for navigating their identity, for helping get that safe space to figure out how I want to evolve, how I express who I am, and also the coming out process and communicating with our family, our loved ones, our colleagues, whomever we interact with. Also, there are care resources to assist with changing outward appearances and gender presentation. So for example, Indiana University's LGBTQ plus healthcare clinic refers interested patients to their hair salon at the university for hair and makeup lessons so that they can more accurately express their gender to the world. Also, there are speech therapy resources that help match vocal characteristics like pitch and phrasing patterns with gender identity. Things like hair removal, right? Electrolysis, laser treatment, waxing. These are things that don't necessarily come up in our mind that could be a part of this conversation around affirming care. Is like, okay, what are the resources you have available that will help you to feel more aligned with your identity? Breast binding or padding is also very common, genital tucking and padding of the hips or buttocks, again, to offer those nuanced changes in body shape. Medications, of course, like HRT, hormone replacement therapy. And yes, surgeries are probably the most common idea that come to our mind, but there are a variety of different surgeries, not just ones that align chest or genitalia with gender identity, but also things like Adam's apple removal. And so it really is a vast spectrum of different types of care that come together that really kind of hopefully move an individual toward more of that gender euphoric experience of alignment. Now, for individuals under 18 years in particular, the timing of the interventions is usually based on several factors, including cognitive and physical development, as well as parental consent. The goal is not treatment, but to listen, build understanding, and create an environment of safety in which emotions, questions, and concerns can be explored. This is according to the lead author of a policy statement from the American Academy of Pediatrics on gender affirming care. So really just supporting everything that we've just talked about. Now, how are you going to get your straight A's here in affirming care? Well, I put this together and I think it touches on all the really important key points of allyship, both on a foundational level, but also on an evolving level. And so first and foremost, we have to acknowledge and accept that we all have bias. We all have implicit bias and discomforts that exist within us. And so seeking ongoing specialized training, clinical consultation, our own treatment perhaps, being curious about where that comes from and how that impacts our interactions with people. This is all really critical for helping us to evolve both personally and professionally, but being able to really lean into how to be an ally rather than just another care provider that's kind of going through the checklist of like, okay, I've done everything ethically or I've done everything correctly here. Next is awareness, right? We want to educate ourselves on the specific needs, resources, elevated health risks, health disparities that affect the communities that we're providing treatment to, right? We want to be on top of recognizing that depending on our community, we want to be have a base understanding of who we will likely be caring for and what those particular needs might be. Being an advocate and assistant is really, really important in this process. So we have to be able and willing to advocate for our clients when they are facing things like discrimination, bullying, overt and microaggressions. I can't tell you how many times I've gotten on the phone with another provider of some kind to have a conversation around how to provide more inclusive, affirming, accurate care that aligns with the care that the individual is receiving in their mental health treatment. And there's a space there of authority that we can lean into that our clients can't, to be able to say, hey, look, we need to be on the same page here. And then, of course, affirm and validate, consistently holding space to recognize your clients' identities and struggles, right? Validate the unique challenges that they face and consider how their intersectionality plays different roles in these challenges. So we're going to just touch on each one of these a bit, starting with that piece around acknowledging and accepting. So there are some key ways that we can explore our own biases and barriers to being more affirming. First and foremost is acknowledging our humanness, right? Acknowledging our humanness helps us stop taking our shortcomings so personally, because we all need to try harder, each and every one of us. And so if you notice that you're holding on to perhaps strong biases, it is critical that you take some additional steps to help prevent harm by addressing them. So for example, one thing that I encourage attendees and other colleagues to consider is the messages, right? The messages that we receive growing up. How did your family, your community, your culture, your religious affiliation, how did they behave toward the queer community, right? Really taking some time and considering, okay, like, it wasn't talked about. That's, some of the common responses that I get are like, it was like, again, hear no, see no, speak no evil, that classic erasure, that classic idea of we're not going to acknowledge these existences, and therefore we will not see the struggles, the pain, the discrimination, the marginalization that they have to endure. Anybody want to share anything about, in terms of, no worries if not, but about like kind of the messages that you received growing up around the queer community? Or I should say toward the queer community?
I just can't help but reflecting, Katie, as I'm raising 2 young children now, right? Just the difference in, for better and for worse, right? Exposure in general, and the ability to have those conversations. Whereas, as a child, I had personal connections and family connections and things that allowed me to have conversations younger. But thinking about some of my peers and, dating myself here, but it wasn't something that was nearly as discussed as I feel like it is in our communities now. And again, that brings positives and negatives. And so I was fortunate that the messages I received were very affirming and safe. I know others definitely were not getting those messages. But yeah, I think the biggest piece for me as I reflect as an adult now, right, is just the enhanced need, I would say, right, for those conversations with the children we're working with, because they're getting so much information from not so many, not always reliable or helpful sources.
Absolutely. It is a double-edged sword, because the inundation of information can also, like you said, can lead to misinformation and disinformation. And when we don't have access to interacting with different people from different communities, then we are limited, right? The messaging is what we're limited to. We're limited to the accepted norms and perspectives, because it can't be challenged. There is no room for that. And so again, going back all the way to the beginning where it's like, oh, well, okay, but kids need a mom and a dad. This is an embedded message that vast majority of people, especially in the United States, have, but across the world, have been given, right? And taught. And without the opportunity to have those discussions, then it very much becomes the worldview. And perhaps even without the understanding of it being a negative worldview, it's simply what we were taught. It's simply a part of kind of the fiber, the DNA, so to speak, of our sense of identity. And so these are the things that we are getting curious about, maybe getting uncomfortable around, and perhaps slowly starting to carefully dismantle with the awareness that this is not a personal failure on our part, that this belief or these beliefs or perspectives have been held by us, but that this is just a part of being cultured. This is a part of being a human, and we've got to, if we want to be an effective affirming provider, we've got to, and when I say carefully, I mean with care, dismantle our own biases as we explore and identify them. So additionally here, we want to lean into our cultural humility, this idea that in order to be respectful of an individual's background, we do not take the authority or the expertise in their lived experience, right? We step back and we say, only you know truly what your lived experience has been like, and we are here to learn from you. Reflecting on our own experiences and interactions, both professionally and personally and socially. I think that's really key, because I think a lot of the times we come into these trainings and we put our professional hats on, and we keep this information in a silo in our professional personas and worlds. And this is something that we want to really start to kind of break down barriers around, like, okay, how do I interact with the queer community personally? Does it happen? Has it happened? What has it been like? And how is that then bleeding into the potential work that I'm doing?
Katie, I'm not sure if you saw too, just to interject, we had some things shared in the chat today as well, kind of leaning into that reflection and personal experience, right? And talking about the experience of growing up isolated and being in a home where acceptance was modeled and kind of encouraged, but talking about the lack of kind of education on why that acceptance and that support was encouraged. And so kind of that, okay, we're naturally in a home where we're going to accept others, but without a lot of understanding or information about why that family was doing that or engaging in those practices.
That's such a really interesting experience to share. I really appreciate that, because I think that might be a very relatable experience, right? Kind of going back again to kind of like, we treat everyone with respect. There's like this foundational sense of care. Oh, a little cameo from Chandler. There's this foundational idea, but without the robust cultural education and understanding, that can then be vulnerable. It can be vulnerable then, right, to different additional experiences or information that we then are exposed to.
And maybe it's my my negative side coming too, but it makes me think about the opposite of that, right? And families who aren't getting even any information about why their adults in their lives or other family members, right, are non-supportive or worse, right, towards other communities and other individuals, but without any information. And so then it becomes difficult as children, right, for us to go, but wait, that doesn't make sense to my brain, right? Why would we be mean to them because of who they're spending time with or who they're in a relationship, right? And so having zero context given to children growing up, right, then it just becomes, we don't like those, those people because we don't like those people, right? And it creates this really potentially dangerous situation from that perspective as well.
Absolutely. Yeah, the very blanketed explanations, right? Of like love the sinner, hate the sin, right? These are very common ones that I've heard in trainings. And it doesn't explain anything.
As a
And
play therapist, it makes my brain go to that, like, we want to avoid because I said so, right? Those parenting, like, classic, whatever. And that's where my brain went, because I said so. And so, thankfully there are experiences where it's like, no, we accept everyone because we do, right? But like the opposite of that can be pretty dangerous.
right. Yeah. And I think it oftentimes speaks to that generational lack, right? Like, again, it's like oftentimes people who are outwardly discriminatory or prejudiced, or, embrace their biases, so to speak, don't know why. They don't really have a strong foundation as to why, and it's usually built again on that lack of experience, that lack of information and education, and the messaging and the culturing that has really kind of set up this weak scaffolding of very strong convictions and ideas. All right, so we're going to keep moving through. I do have a very cool thing to share with you with this particular element of the straight A's allyship model here. But additionally, we want to consider how interested you feel in learning about these communities. I think that's a very relevant and fair thing to really explore. Notice if you are taking this training and you're doing it to check off some boxes, and it's like, I don't really have the time, energy, interest to really explore this information or become more affirming by learning about these details and this information, and getting, having my language terms list available. That is something that I think many people will feel while engaging in trainings like this. And to that, I would encourage, right, to say, hey, okay, so perhaps maybe just consider that as a factor. Just having an awareness that I don't really feel a lot of interest in exploring this, learning about this, shifting these beliefs, or even just exploring these potential biases, that does speak information to your awareness. At the very least, it might be that you are not fully ready to take on particular clients and be able to provide that affirming care that they really desperately need. And so that can maybe help you make an informed choice when taking on new clients or providing referrals to someone who would be able to offer that more effectively, at the very least, right? Sitting with the internal experiences that come up during our training or after today's training, that's another great way to get started in this process of acknowledging and accepting our own biases and barriers. And I do want to include, I'm going to add it here in the chat box really quickly, this link for the Harvard Implicit Association tests. This is a very cool tool. If you are curious in exploring the potential biased associations that you might hold, and they're implicit, right? So again, we're kind of digging a little bit deeper into that space of like, that might be uncomfortable to dig. But, if you're courageous enough to kind of explore these, I think there's like 18 of them, and they span a bunch of different concepts and topics. And they essentially, it's a rudimentary test of kind of matching, and it gives us some insight into the potential biases that we hold toward different communities and identities. So I highly, highly recommend exploring that. There's a variety of them that you can explore and just get a little bit more insight about your potential implicit bias associations. Talking a little bit about staying informed about increased risk and health disparities is also a key piece of being an ally here. And so we need to be aware that there are higher rates of things like anxiety, depression, cancer, PTSD among the queer community. Now, when we're talking about things like anxiety and PTSD, especially among Black trans folks who have been increasingly and repeatedly and unwillingly exposed to anti-Black violence, discrimination, anti-LGBTQ rhetoric and legislation like we've been talking about, whether through direct experience or just witnessing these events unfolding around us in the world. We can't escape this. I think we can all relate to that. There is no escape to the current political climate and the current unfolding of anti-LGBTQ legislation all around us. It's a direct impact, whether we like it or not. And so these things play a significant role in the development of anxiety, depression, PTSD. Now, cancer risk, higher cancer risk, that was something that I learned as I did my research into this, creating this training, which was really interesting. So there's research that shows that queer women may be at higher risk for colorectal cancer, skin cancer, cervical, endometrial, and ovarian cancer compared to their cis hetero peers. Now, we don't know exactly why this is, but there are some speculations, including higher rates of tobacco and alcohol use, but also the role of nulliparity, which is a term used to describe someone who is either delayed childbirth or never given birth, and that impacts our endocrine system and our reproductive organs over time. And so these higher rates are certainly influenced by a potential number of variables, but they are certainly influenced by the effects of discrimination and the elevated chronic stress that's commonly experienced by marginalized communities. There's also, again, awareness of access to barriers, access barriers to treatment. So we talked about this a lot, familiarizing yourself with local and regional legislative issues, discriminatory laws, barriers that can span from financial to physical, right? Like literally getting in and out of a building for a specialist or a provider of some kind. These are just some examples to be aware of. It's also important that we have a general knowledge of preventative care. So while we are not medical providers, it really behooves us to have some general knowledge of what our queer clients may need education around, or at least just support around. That includes things like potentially accessing and utilizing daily PrEP medication. There's also which, if you're not sure, PrEP is a medication that's taken daily that helps reduce the risk of HIV infection. But there's also now Apretude, which is a every 2-month injection of a similar medication. And so these are options, right? If you're having a conversation with a client who is struggling to be medication compliant because maybe they also have ADHD and they just struggle to remember to take their medication, but this is like a really important health issue that they know they want to be on top of. So these are some options that we can offer them in terms of education. It's like, okay, well, maybe this will fit better and protect you more effectively. There's also information around PEP, which is the post-exposure medication that can help prevent and manage HIV infection. They also might need to know information about puberty blockers and other, again, gender-affirming care and procedures like we've listed before. If you're having these conversations around gender dysphoria, it might be worth having this conversation to throw out, hey, okay, so maybe maybe there's a trip to the nail salon in your future. Would that do something to help institute a self-care practice that would be identity affirming and just help manage and cope with the daily struggles? Something as simple as that could be very useful. We also need to be aware, right, of the higher exposure to trauma and violence and the consequences that come, right? And so it's obviously no surprise that there are significantly higher experiences of trauma across the lifespan for the queer community compared to the cis-het community. And that, of course, includes child abuse and sexual and physical assaults. Research also shows that queer people who live in communities with higher levels of prejudice die sooner, on average about 12 years, compared to those living in more progressive and accepting communities. We got to advocate and assist. That is a really crucial element of our role, isn't it? So we want to consider the different ways that we can do this. As you become more aware of the issues that are affecting the queer community, raising awareness among your colleagues, your family, your friends, this is the space that you might find the most uncomfortable, right? This might be, it's kind of like, but I can provide affirming care behind those walls in that session, no problem. But it's when I get into my personal spaces that it's a real challenge. Well, then I would encourage you to lean into that, because you're probably really doing a great job in these other areas. And it's this other space that does significantly affect the queer community, just from what might feel like a distance. Advocating for legislation, we need that more than ever. Being vocal, contacting our local legislators, and really being vocal about supporting health services, civil rights, and equity. I've listed here a number of kind of local resources to my area, but also some national resources. But I also have a QR code in the next slide so I want you to have your phone ready, because those are Iowa specific resources that you're going to be able to access, that are from the University of Iowa's resource list. It offers on-campus, citywide, statewide, and national resources. This is an essential tool for advocacy of our clients, friends, community. Finally here, talking about care coordination advocacy. That's another element that I think can be very intimidating sometimes, depending on who we're coordinating care with. And so we want to maybe, again, this is where we do some of our own work and leaning into our own enthusiasm, our own personal values around being brave and courageous. We want our clients to be brave and courageous in their lives, and we're going to embody that when we pick up the phone or when we hit send, or we, make that email, to know that even though this might not be the friendliest recipient of the information, you are here to, again, take some of that burden off of your clients' shoulders, who might feel very alone and potentially re-traumatized by the care that they're receiving. Here's that QR code. Please be sure to scan that, because, again, these are state-specific to Iowa that give you a beautiful variety of resources, including those, again, on campus, which really speak to the young adult and youth services that you may be running into when you're providing affirming care. Thumbs up, we good? Everybody got it scanned?
Yes, that was great. Yeah, that came right up.
And finally, I just want to hit on this affirming and validating element that I'm leaning into the LISTEN model for. The LISTEN model is not mine. It was created by the International Institute for Trauma and Addiction Professionals, but I like it. I like it because while it lists off these steps that as providers, we might feel very confident that they're kind of ingrained in our soul as a care provider. But what I want us to look at it from, the lens that we're looking at this model from, is from the lens that we might not be showing up in every room, in every session with every client in this way. And so this is a fantastic tool to be able to kind of support us when we are maybe having some difficulties with our own implicit biases in providing this affirming and validating care. So it goes down and it specifies, being able to provide that safe environment by listening actively, by being very, very present, so that our client does feel safe to openly express and feel heard, even if it's expressing things that, might seem like, oh, well, this might offend you, but I'm going to tell you anyway. Great. We want our clients to say it anyway, because that really shows that they do feel a sense of safety with us, even though they get the sense that, oh, this might not land well. Imagine is about using our creativity around posing questions to clients for them to kind of consider the impact of their choices on their lives, but doing so with those really creative, reflective questions. Another tool that I offered is the open-ended questions handout. These are some, and some of them are specifically geared toward identity and inclusive affirming questions. And so these are the areas that we want to be creative in and kind of help our clients kind of mine and explore these spaces, but in a safe way, in a way that they're not getting that sense of like, why are you the way that you are? Because they get that a lot. Self-determinism for me is essential, key, imperative. We need to consistently be providing that support and affirming environment, no matter what our clients choose. That sense of autonomy is an ethical duty, and it is really the only way to effectively help people, is that they feel like they are the authority and that they can come to you as their essential supporter, even if they don't do the thing they said that they were going to do, or even if they do the thing they said they weren't going to do, that we are there to walk with them and not judge them and be supportive and open with their choices. Building that trust, of course, having that open door communication. Again, this can be tough when maybe not when we are feeling super, super comfortable with a client, but when we are not necessarily feeling particularly comfortable. The way that we communicate our implicit bias is usually non-verbally and paraverbally. And so we are not necessarily saying these things, of course, out loud, but clients can read them. And that impacts trust, the ability to build that strong therapeutic alliance. And so these are these spaces that we might need to pay more attention to, because we might assume we're like coasting, we're doing great, and it might not be the case. Of course, demonstrating that empathy and compassion for those specific lived experiences and struggles, and then effectively being proactive and helping clients take the next steps that they choose. And again, it could be, that your client is just recently coming out, just recently exploring their own sexual orientation, and they want to start dating and they have no idea how to do it, and they're terrified. Navigating that process with them would be invaluable. So just a few other considerations that I'm going to quickly skim over here. Using inclusive language isn't just about how we speak in a session, right? But thinking about the signage that we use, right? Thinking about even just like product placement. Having a simple gesture in the background of our screen of our telehealth work without any words spoken speaks volumes about the potential safety and inclusivity that we can be providing to communities that often feel invisible. Things like gender neutral restrooms, if you have an office, having open promotion of queer services and resources, not just in sessions, but in the lobby, right? Like on the walls in the hallway, just regularly accessible to anyone who might be there. Being open to feedback is really, really important. There are a lot of creative ways to get feedback these days, anonymous feedback from clients and customers. And so that's something to consider both as an individual provider and also if you're running an organization or an agency, and making sure that you have a really decent network of queer affirming referrals. That is essential because it is not a big community, depending on especially where you're at. And so every single referral can really go the distance in helping your clients and providing that safe, affirming care. So y'all, by taking these steps, we can, as health providers, play really, really significant roles in improving the health and well-being of the queer community and beyond. And that is how you get in touch with me. So if you want to contact me directly, you can scan that QR code and get all my stuff.
Perfect. Thank you so much, Katie. There's so much great information in this. Katie mentioned it at the beginning, but I want to reiterate as well. Katie does offer one-to-one communication coaching for individuals. She has a 6-week Boundary Builders group coaching program. And anyone is welcome to schedule a pressure-free intro session with her to discuss communication coaching. We will have the link to do that in all of our notes for the show. I'll put it in the chat box for those of you that are with us today. She's got that great QR code there. So feel free to check that out. Please do to check out Katie's services, connect with her directly. And Katie also has a free educational Facebook group called Communication Skills for Connection. She's also on Instagram, and we will have both of those links in the show notes as well. So please go follow her, check her out. So much great information there. If you are new to doing a live training with us, as well as those that are watching the recording, for those watching later on, you will also get a certificate link for your CE certificate. We do use a HIPAA compliant platform. And so when you complete that, it will give you a little password. Just paste that password in the pop-up box, and that will open your certificate to download. So if this is your first time doing that, it can throw people off a little bit. But yeah, Katie, we cannot thank you enough for all of this information. So.
Well, I so appreciate you guys, really sincerely, and not just showing up, but participating. It's always such a pleasure to get to chat about this and interact with everybody. So thank you.
Thank you for joining in on today's training. We look forward to having you join us again. Heart & Solutions is proud to provide CE-eligible trainings for our counseling community. This training may be eligible for continuing education credit hours through either the National Board for Certified Counselors, provider number 7376, or the Association of Play Therapy, provider number 21-645. To obtain CE hours for today's training, be sure to follow the steps in the description below.